discussion. Dr. Revant Kapre from is a third-year junior resident at Imambara Shodhar Hospital. So he will be facing the operative scenario, and Professor Shubhajyoti Ghosh, who has a lot of interest in hepatobiliary and pancreatic surgery, will moderate the session today. So Revant, you continue with the question answer session first, and then Dr. Ghosh will give us a brief overview of this operative procedure. So Dr. Ghosh, you can start the proceeding with the indication or whatever you feel we can start.
Thank you, Professor Saha. Good morning, everybody. I just want to tell you one thing, that chronic pancreatitis is a rather common disease in this part of the country, in the whole of the eastern region. So we get a lot of cases of chronic pancreatitis everywhere, every district in West Bengal. So the surgeon should be quite familiar with the disease process of chronic pancreatitis. And so it will be a common operative topic during your final MS or DNB examination. So I think you should be well prepared with the operative steps. And you might be asked a few questions on chronic pancreatitis during description of your operative steps. So just think that you have got a card on which it's written that lateral pancreaticojejunostomy. Now you'll have to start telling us about the operative steps.
Good morning, sir, and all my colleagues. Myself, Dr. Revant. I'll be discussing the steps of lateral pancreaticojejunostomy. So, starting with the position of the patient, and the position of the patient should be in supine position, with or without keeping a holster in the back of the patient, so that the pancreas will be little bit elevated. The anesthesia of choice will be general anesthesia with intubation, and then we'll start the procedure. The incision, the abdomen should be sterilized with betadine from the nipple till the thigh. Then then the dressing and the draping will be done. After that, we can. There are three types of incision we can use. In a thin patient, we can use a midline incision. Then we can use a rooftop incision, that is bilateral subcostal incision, also known as chevron incision, and also we can use a right makuchi incision for better of the patient, better view. Then after opening the abdomen and cutting all the layers.
One point here. Right. So choice of incision also depends upon the patient's habitus, right?
Yes, sir.
And bilateral subcostal incision is a good incision for expose of the pancreas. But sometimes the orientation of the pancreas is more like vertical oriented instead of transverse orientation. It sometimes you will get the pancreas is in a vertical oriented in a vertical positions. So in such patient, through bilateral subcostal incision is very difficult to reach the tail of the pancreas. So midline incision sometimes is very, very useful. In fact, in all patients I have done, it's very useful, not only for quick entry and also quick closure. And second thing, when you are talking about the Makuchi's incision, always remember that you must have a very good abdominal retractor in your operation theater. Otherwise, you can't use that incision for pancreatic surgery or for any upper abdominal surgery. Okay.
Okay, so after opening all the abdominal layers, then we'll see the organs, and we'll see for any foreseen pathologies which has been missed earlier. For example, any liver mets or any omental metastasis. Then we'll proceed with the First we'll use a cattle brush procedure for medialization of the right hepatic flexure. The right hepatic flexure will be moved medially.
First step is the wide cauterization. So the whole of the pancreatic head comes under your hand, left hand.
Yes, sir. Yes, sir. So first we'll use do the cauterization so that the whole of the pancreatic head and the C-shaped duodenum will be in our hand. We'll use it by using electrocautery, and the dissection should be till the superior mesenteric vein. Then after the cauterization, we'll go for the head and we'll go towards the left side, and we'll dissect the gastrosplenic ligament and the gastrocolic ligament, so that the body and the tail end of the pancreas will be visualized. After that, we'll try to palpate. When the pancreas is visualized, we'll try to palpate any stone or the duct.
No. At this point, you need to do the kettlebells, as you said. That should be the third.
Yes, sir.
You have to achieve the whole of the C loop of the duodenum as well as all
sir. After.
head. So first operation, second gastrocolic ligament, taking down the gastrocolic. Third is kettlebells, so that the hepatic flexure is down and whole of the head of the pancreas and ancillary process is well
in
visualized.
our hand. Yes, sir. Well visualized. After that, we'll try to find the main pancreatic duct. It can be found by using.
How do you find the main pancreatic duct?
So main pancreatic duct. So we can use our index finger and the thumb. If any stone is present, we can palpate it. Some other ways is we can use a whiteboard needle to pierce the pancreatic.
Where? Which point? At which point?
Yes, sir. I'm telling you, at the level of the neck, upper 1/3 and lower 2/3.
At the level of neck, the most dangerous. At the level of the neck, which is there underlying.
It's inferior vena cava, the portal vein.
No.
At the level of the neck, just below the neck, what do you do? There is the superior mesenteric vein and formation of the
superior mesenteric vein, sir, and the formation of portal vein, sir. Sir, we go medially 1 to 2 centimeter medial to the neck.
After you expose the head of the pancreas, next part is you have to define the upper border of the pancreas and the lower pancreas, right? So there will be a lot of additions with the stomach. Sometimes additions are there between the stomach and the anterior surface of the pancreas. So all the additions should be taken off, and you have to define the superior border as well as the inferior border, right?
Yes, sir.
Pancreatic duct is exactly in the middle point between the superior and inferior border of the pancreas, right? So it is always better to, if you palpate, in case of chronic pancreatitis, pancreas becomes hard. So if you palpate the anterior surface of the pancreas, so you find some soft areas, right? Cystic areas, which are the dilated pancreatic duct. So that can be palpated, right? Even if that is not palpable, then you will have to put the needle exactly in the midpoint between the superior and inferior border of the pancreas, and slightly towards the body of the pancreas, away from the neck, on the left side.
So once the pancreatic duct is confirmed, then we'll start opening the pancreas. Then we'll open the pancreatic duct using the electrocautery, and once the pancreatic duct is opened, we'll use a trocar, a metal trocar, to find both the ends, the head end and the tail end of the pancreatic duct. Then using the trocar only, over the trocar only, we'll use a electrocautery to open the pancreatic duct towards the tail and towards the head. Once the pancreatic duct is open, we'll take out all the calcification, all the calculi, or if anything else is there. Then the pancreas is laid wide open, and then the next step is making of the limb. The limb is
how far you will open the pancreatic duct?
So we'll open the pancreatic duct from the head till the tail end, sir. The whole of the pancreatic duct is open, sir.
Up to the sphincter of Oddi will open?
No, sir. Sir, leaving the sphincter of Oddi, sir.
How much? What is the
so 1 centimeter, sir. One centimeter. Was 1
centimeter. 1 centimeter medially and 1 centimeter laterally.
Yes, sir. 1 centimeter medially, 1 centimeter medial from the duodenum, sir. Then, sir, we'll create a. Then we'll check the patency of the duct, sir. Yes, sir. Sometimes if some stone is there, sir, we can use
checking the patency. It is clearing the stones in the head.
Yes, sir. Clearing the stones in the head. Then, sir, we'll create the rule limb. The rule limb is taken 15 to 20 centimeter from the DJ flexion, duodenal jejunal flexure, and the rule limb is taken behind the transverse colon from the mesocolon by creating a rent of the mesocolon in avascular area. And while we are doing it, while the resection of the jejunum, if there is any bleeding from the vasa recta, we'll tie it with the cell cord vessel. Then we'll take the rule limb behind the transverse colon towards the pancreas, and then we'll lay over the jejunum as per the opening of the pancreatic duct, sir. Then we'll start suturing.
Exactly the size of the length of the opening of pancreatic duct should match with the length of the jejunum.
Yes, sir. Yes, sir. Jejunum. Yes, sir.
No. Jejunum is always stretchable and it gets wider. So always cut the jejunum at least 1 centimeter less than the length of the ductotomy, pancreatic duct, opening of the pancreatic duct.
Okay, sir. Then we'll lay over the pancreatic duct. Then we'll start suturing the first layer. We'll suture the seromuscular layer of the jejunum with the pancreatic parenchyma. Once the first layer is done, then we'll open the jejunum. Then we'll suture the open end of the jejunum to the upper open end of the pancreas, and then we'll continue suturing with the continuous suture, so that the new pancreaticojejunostomy is done, sir. Then the remaining jejunum, it is fixed with the remaining of the jejunum is fixed in a Y-shaped manner at from the new pancreaticojejunostomy stump, 35 centimeters from that, sir. Then all the abdomen is closed. But before closing the abdomen, we'll put a drain and check for any other bleeders, sir.
Okay, so that completes your operation. Okay, reasonably well description of the operative steps. But when you talk about lateral pancreaticojejunostomy, particularly chronic pancreatitis, there will be a few more discussions on chronic pancreatitis. So first of all, you should have told us about the indications of lateral pancreaticojejunostomy.
Yes, sir. The indications of lateral.
Regarding the steps also, I think he has missed some important points. You see, when you expose the head of the pancreas, two important vein comes. Unless you tackle these two veins, it might get torn. What are the two?
So
when you are exposing the head of the pancreas by cattle brush and copperization, two important vein comes in the way.
The gastroepiploic vein.
Right, gastroepiploic vein
and the superior mesenteric vein, sir.
No. It is the main trunk, two tributaries, and the pancreaduodenal vein.
Yes, a pancreaduodenal vessel.
Yes, and the way you describe now, but I prefer that you describe the operative steps in a different manner. I always prefer that. It's a big operation, you see. LPG is a very big operation. So you make clear headings. Number one is opening the abdomen. Opening the abdomen. And don't start saying 3 incisions. It's a practical examination.
Okay,
you are facing a practical examination. You just keep on describing one particular incision. I'll go by bilateral subcostal incision.
Yes, sir. Bilateral.
These are things I cut through. Number one. Yes, number two is exploration of the abdomen. You started saying liver metastasis or omental deposits. We are operating on a patient who has got chronic pancreatitis. Idea of exploration of the abdomen is confirm the diagnosis is a chronic pancreatitis, number one, and look for any other pathology. Patient might have associated gallstone disease. Patient might have associated CBD obstruction leading to CBD dilatation. So, next heading is exploration of the abdomen.
Yes, sir. Exploration of the abdomen.
Next heading is exposure of the pancreas. Exposure of the pancreas. Under this heading, you will have cauterization, cattle brush, opening the gastrocolic ligament.
Yes.
Okay, and while doing so, you tackle these vessels. So, this expose the pancreas. Next is identifying the pancreatic duct.
Yes, identify.
Okay, that can be done number one by palpation. Number two, by puncturing the duct with the needle, seeing that juice is coming up. Okay, so that is how you identify the pancreatic duct. Next is creating a ductotomy.
Yes, sir. Creating a ductotomy.
Okay, so you open the duct, and as you described, open the duct towards the head end, short of 1 centimeter, on the tail side 1 centimeter. So ductotomy is done, and removal of all the stones by using a disjarding forceps and by flushing.
Yes,
Next is creation of loop. Then a pancreaticojejunostomy anastomosis. You describe one technique, either single layer or double layer, whatever.
Double layer, sir.
Don't start describing all the options available. So you describe the particular technique you are following in a particular situation, and then the jejunostomy. So if you make headings, your decision become complete. You can take up all the points which is required in the particular step. And now come to Dr. Ghosh's question. What
Yes,
the indications? Yeah.
Right. So you should describe whatever you have seen, and not necessarily what's written in the book, right? If you have seen the operation yourself, so what your boss is doing, you can describe those steps, and I think that will be a better way of presenting in a operative steps. Okay. So whenever you start this any operative steps, any operation, we start with the first indications for the operation. Then comes to the if there is any particular preoperative preparations that has to be said, then the patient in the operation theater, right? So now let's start with the indications of the operation. What are the indications for lateral pancreaticojejunostomy?
Sir, indications are intractable pain with failed medical treatment.
Yes.
So then
Intractable is somewhat a vague term, right? So intractable pain with failed medication, failed medical management, which is occurring with the pain which is occurring daily, right? Or that is affecting the lifestyle.
Yes, sir. If affecting the lifestyle. Sir.
Okay. Next.
So then there's CBD obstruction. Then there's duodenal obstruction. Then sir. So pancreatic ascites, sir, and then sir, there's recurrent acute attacks of appendicitis. Pancreatitis, sir. Then there's suspected malignancy also.
Yes, almost there. So first thing is the intractable pain, which is occurring daily in spite of the medical management or affecting the lifestyle. Number two, any obstructive symptoms, right, which include obstruction, duodenal obstruction, or portal venous or the splenic vein obstruction, or splenic vein thrombosis, and if there is pseudocyst. Right. And next group is inflammatory head mass.
Inflammatory head.
And next,
I forgot to tell head coring also, sir. So we are supposed to do head coring.
We'll come to that.
No, LPJ,
it was LPJ description. Now,
yes,
Dr. Ghosh will ask you what are other additions to this operation and why it is needed.
And last is that if there is suspicions of malignancy.
Yes. Yes.
Right. So in those cases, this operation for chronic pancreatitis should be undertaken. Okay. So not necessarily this lateral pancreaticostomy.
Okay.
Right. And one indications of pancreatitis, if you are asked strictly about the lateral pancreaticostomy, not head coring or other options, so it should be done when the main pancreatic duct is dilated without stricture or stenosis of the side branches. Right.
Yes.
If there is stricture or stenosis of the side branches, simple lateral pancreaticostomy may fail to relieve the pain. Right. Now, can you tell me what are the causes of pain in chronic pancreatitis?
So, etiology, sir.
No, yes. Pain. What is the mechanism of pain in pancreatitis?
Why there is pain in chronic pancreatitis?
What happens?
So, because of the nociceptive receptors, the pancreatic parenchyma, it expands.
Why? Why? One is ductal obstruction.
Yes, a ductal hypertension. Sir.
Increasing the pressure. Second,
pressure.
One is ductal obstruction. Second,
yes, sir, the infiltration by the inflammatory cells, sir.
Not infiltration. What happens in pancreatitis? Chronic pancreatitis, there is fibrosis.
Fibrosis is a chronic.
So what happens because of fibrosis? What happens because of fibrosis?
Sir, the pancreas does not function, sir.
No. You're not talking of, you're talking of pain. What happens to the nerves around the pancreas?
So the edema, they get compressed, sir.
Yes.
So the nerve density increases, sir.
Okay, there are many hypotheses regarding the origin of pain in chronic pancreatitis. Okay, so none of this is still foolproof. So there is, as sir said, a dilatation of the main pancreatic duct. Any ductal dilatation may cause pain, and there may be parenchymal hypertension, right? Because there is fibrosis, so the capsule gets contracted, and there is parenchymal hypertension. There is ischemia to the gland because of this.
Yes.
That may also produce pain. But nowadays, which is commonly accepted, is the neurohumoral crosstalk. There are a lot of neuronal changes within the pancreas. The nerves supplying the pancreas, these nerves in course of time, due to some overactivities of oxygen free radicals, the nerve endings, they get damaged and they get demyelinated. So in the process of that causes a persistence of pain. So these are the theories, but this neural theory is latest, that is being accepted all over. Okay.
Where is the pacemaker of pain? In pancreas?
It's the head of pancreas, sir.
Yeah.
Yes. Why head?
Sir, because all the ducts are opening.
No, basically head is the junction where the embryological fusion of the dorsal ventral bud and the
Yes, sir.
This dorsal and ventral bud, pancreatic bud fuses. So embryologically, potential varieties of totipotential cells are there. Okay, so that is the reasons why it's said that the head is the pacemaker of all the pathologies in chronic pancreatitis. Okay. Okay. Next one, it will be nice if you could describe during your operative steps that we, at least our residents, they always display all the imaging investigations in the operation theater. Suppose if you have a MRCP or if you have a CT scan, so we all display those plates over the view box. So that is a good roadmap. Sometimes you just get lost, and again if you go and check the CT scan or the MRCP plates. So that is a roadmap that will help you to reset your mind. So that is a good way of starting your surgery. Right. Now you have done the operations and everything's fine. You are put in the drain. Now you tell me the complications that may encounter.
Sir, acute hemorrhage might be there, sir. Then, sir, reactionary hemorrhage could be present. The failure of the pancreaticojejunostomy could be present. The failure of the.
What do you mean by acute hemorrhage?
So means after the operation, under 6 hours, sir.
No. While operating, talk of some complication on table.
Start with intraoperative, early postoperative, and late.
Yes, sir. So intraoperative, sir, hemorrhage could be present, sir. Then, sir.
You have some bleeding while cutting through the pancreas. How do you manage the situation?
So we will use a silk, sir, to tie the bleeder, sir, or we can use
some energy source.
So electrocautery can be used, bipolar can be used, sir, and so yes. We can always use.
Or you can underrun this spotting vessel.
Yes, underrun the spotting.
By using very fine pulling suture, maybe 30 or 40 pulling suture.
Yes.
Right. So there are many ways of controlling the bleeding beforehand. If you think that pancreas is too much vascular engorged, so it's always better to take the U stitches around the head of the pancreas. If you take serial U stitches and tie it, so that way you can expect to reduce some of the bleeding during operation. And another step is that ligation of the gastroduodenal artery. Some surgeons, they routinely ligate gastroduodenal artery before doing surgeries on the pancreas, like on chronic pancreatitis. So these two may reduce bleeding to some extent. And even if there is bleeding, then probably the best energy source to control bleeding is the bipolar forceps,
Yes.
right? Usually it bleeds from the wall of the pancreas.
Pancreas.
Right? So if you just keep the bipolar over the wall, not try to hold the bleeding vessels, just keep the bipolar forceps wide open, and in between your forceps tips, the bleeding point will be there. And now if you press the coagulation switch, it will be coagulated and nicely, and there will be less bleeding. Okay. And so bleeding is the most important
Yes.
complications, important aspects during the surgery. Now, in the early postoperative period, what may be the complications?
So early post-operative period, sir. Failure of the pancreaticojejunostomy.
No. Before that, again bleeding. Even in
Yes,
the
sir. Yes, sir.
post-op period, there
Reactionary
are
bleeding is a
a lot of
post-op
raw
bleeding, sir.
areas. Patient might bleed post-op.
Yes, sir. Post-operative
So,
bleeding.
even the early bleeding is one important post-op complication. Okay, next you are trying to say pancreatic fistula or breakdown of the anastomosis. What are you trying to say?
Yes, it's a breakdown of anastomosis and the pancreatic fistula.
How is the incidence of pancreatic fistula in chronic pancreatitis versus fistula in Whipple's? Don't know. What happens in chronic pancreatitis? The pancreatic exocrine secretion is less or more?
So
Less.
it is increased. Yes, sir.
It's less, not increasing.
Yes, sir.
In chronic pancreatitis, there is decrease of exocrine secretions.
Exocrine, yes.
Okay. In Whipple's is a normal functioning pancreas. So the risk of fistula is more in Whipple's than in chronic pancreatitis. So, but still it can happen. Okay. And then you said there is anastomotic leak. The leak will result in pancreatic fistula again.
Yes.
Okay. Anything else? Any other complication in the post-op?
So multiple adhesions could be there. Post-operative iatrogenic adhesions.
Adhesions is long-term complications. It doesn't happen immediate post-op.
Okay, what is the long-term complications of this operation, lateral pancreatitis?
So stricture, sir, and sir.
Where stricture? How most of the patient comes up in the post-op period, long term, maybe 6 months, 1 year, 2 years. They come back with what?
So they come with the same things, sir. Pain,
yes.
Sir.
So,
pain, yes.
Pain. Yes, so recurrence of pain.
Recurrence of pain, sir.
Yeah.
Then we can.
So what do you do if the patient again complain of recurrence of pain after say 1 year follow-up?
So we'll do the investigation, sir, against the CCT, abdomen, MRI, sir. Then we find the cause of pain. Most probably, sir, it could be a stone. Again, the stone impaction could be there. Sir.
No, stone load is not the cause of pain, right? First of all, you'll have to examine the patient and you'll have to decide. You'll have to see whether it is a pancreatic pain or it is extrapancreatic pain, right? In our country, patient comes with so many types of abdominal
pains,
right? Vague pains, amoebasis, these are so common. Or patient may have chronic duodenal ulcer. So first you'll have to decide or exclude the non-pancreatic pain. Now, if you think the pain is due to chronic pancreatitis or failed operation, then you'll have to do something. Now, what are the options you have in that case? You have already operated the patient.
So first we'll diagnose the patient. So why the pain is coming? Why he's suffering from pain? So if it is because of the operation, then we'll we can say we can do ERCP, sir. If the stone is present.
How ERCP can help?
There
is a particular situation where some patients are managed by ERCP.
The sphincter of Oddi might get dilated, sir. So
dilated.
We can use.
There might be a stricture in the sphincter Oddi.
Stricture, sir. Sorry.
There might
of the
be a small stone laid behind in the region of the head of the pancreas.
Yes, sir. So we can.
So endoscopy
you have done wide lateral pancreaticojejunostomy. So how does any obstruction on the sphincter Oddi level will give rise to pain. You have the ductal drainage is there. Duct is already draining nicely. Such a wide anastomosis can be installed.
So it might get fibrous, sir. You can put a stent later. If it might happen.
No, so basically it is a recurrence of the same mechanism. That's why there is recurrence, not related to ductal obstruction or anything else, right? Usually after pancreaticojejunostomy, wide pancreaticojejunostomy, stenosis fractures is very rare. So first of all, you'll have to, of course, in any chronic pancreatitis, you will have to give supplementation of pancreatic enzymes, right? Along with oxygen, lot of nowadays oxygen-free radicals, these various types of
Antioxidants.
elements, antioxidants, right? These are given, and it's said to be have some relief from the pain. Along with that, if that doesn't work, then you'll have to give this step-up approach of analgesics.
Yes,
right?
sir.
If that fails, now if that fails, then what option you have? If the patient is not well controlled with the oral analgesics, then what is supposed to do?
So first we can try NSAIDs, then we can try low strength opioids, and then after that we can admit the patient in the ICU or HDU, and we can give higher opioids or morphines. And even after
we have one option, celiac plexus block. If these fails,
yes, last celiac plexus block.
Not last. Celiac plexus is not last. Now, how long this celiac plexus block works? On an average, for some patient it works very nicely for quite a lot, even after 10 years. But on an average, how long it works for a patient? Usually 3 to 6 months. 3 to 6 months. 3 to 6 months. Right. So after that, patient may again have pain. Okay. So these are the things. These are common scenario. If you do lateral pancreaticojejunostomy and if you follow up the patient, and patient may come after 1 year or 2 years again recurrence of pain. So you'll have been a surgeon particularly if you have operated. So you'll have to manage the patient, right? Even if the celiac plexus block doesn't work, then what options you have?
So
okay, so you'll have to again explore and as you said, the head is the pacemaker of this origin of this pain of chronic pancreatitis. So we'll have to go for head resection, maybe, right? So maybe the biggest operations, or maybe in extreme cases, if you think that malignancy may be coexisting, so we might have go for Whipple's operation, right? So, Dr. Shah, Professor Shah, anything else? You can
yeah. If you like to have some presentation on this, you can have.
So I was told to just to tell the steps. So
no, you need not. Dr. Ghosh will give us a glimpse of this topic.
Right. So actually, even if you have these operations in your operative steps,
if I ask Dr. Ghosh, if I ask him few important yes, what is this operation goes by the name of?
It's a phrase operation.
No. This LPJ, if you're just doing a LPJ, not doing head coring, is a modified push-to operation.
Yes, a modified push-to operation.
What was the original push-to operation?
So in the original push-to, yes, sir. So originally, sir, we used to cut the tail end of the pancreas, and we used to put the jejunum in the pancreas would get invaginated.
That is Duval you are talking of.
It's Duval, yes.
It's Duval procedure. Original push-to was a longitudinal PJ associated with splenectomy and distal pancreatectomy, and invaginating this long opening in the duct into the jejunum. That was original push-to. Who modified this?
Parrington Rochelle.
Yes. And modification is this. You did not do a distal pancreatectomy or splenectomy, you just do the anastomosis. Okay. While doing phrase procedure, how much you excise? How much in the head region you should excise? What is the limit?
So 1 centimeter from the duodenum, sir, we can do the head coring, sir.
And if you go deeper?
So 1 to 2 millimeter we can go.
Only 1 millimeter?
No, sorry, 1 to 2 millimeter is left, sir.
Where?
Sir, the posterior part of the head, sir.
Suppose you are trying to find the duct. You cannot open the duct. You cannot find the duct where it is. What step you should take?
So we can say use the dye. We can
Where?
use a dye, sir.
Where you use a dye? You cannot just,
No,
you are not
no.
localizing the duct.
Yes,
By
sir.
puncturing, by palpation, then
Yes,
what
sir.
do you do?
So we can do the extensive head coring, sir. So we might find.
No, that is not it.
No.
If you are not finding the duct, you can make a small vertical incision on the entrance of the pancreas to the left of neck. That is not on the side of the supramesenteric vessel of the portal vein.
Okay.
And if you make a deep cut, you can identify the duct. And from that, you can go towards the head and go towards the tail. You are operating on a patient who does not have dilated duct, but classic pain and everything. What is the modification for that operation? Duct is not dilated.
Small
But
duct disease. Rather, it's called small duct disease.
Yes.
Yes, sir. ISBK operation can be done.
Yes, sir. Good. What is that operation?
Sir, we'll do a V-shaped wedge resection of the pancreas and the pancreatic duct.
On the anterior surface.
Anterior surface.
You remove a waist-shaped core of pancreatic tissue.
Pancreatic tissue.
Same from tail to the head region.
Head region.
To the anastomosis, pancreas. Good.
Yes.
That's good. Yes, Dr. Ghosh.
Yeah, I had made a small presentation. Actually, this is a presentation made for students of Kolkata Medical College. It's a long time back. So I think it would be nice if you can share this with you. Just a second, please. Okay. Can you see the screen?
Yes. Invisible.
Thank you. So I'll just quickly go through some of the slides. And right. So you can see nicely here MRCP picture of chronic pancreatitis. So these are the main pancreatic duct, and these are full of stones. And we operated on this patient, and you can see the stones here nicely. So I think I just wanted to give you one idea how you can document, right? So if you nicely just take the picture of your MRCP frames, and alongside if you just put up the stones, I think that is very interesting to observe. Now, remember that basically it's a non-operative disease, chronic pancreatitis, and only we operate when there is patient has some either intractable pain or complications. So basically everywhere when you go to any conference or other surgical conference or medical conference, you always see chronic pancreatitis is basically a non-operative disease. So initially it should be treated with medicine first. So these are the pathomechanism. I think you know it all Taigaro. So I'm not going to tell about this. So basically goal of surgery is to give the pain. So that is the main target. So you should counsel the patient that the surgery is all because of the pain, and it is not going to stop the disease process, because chronic pancreatitis is a progressive disease. So along with that, sometimes some of the palliations, like if the patient has obstetric jaundice, so those has to be taken into account. And so surgery cannot cure the disease. That's the point. Now, the indications already we have discussed. So intractable pain, daily pain, not responding to the medical management, or local complications like jaundice, portal hypertension, head mass, or suspicion malignancy. And this is interesting that nowadays a lot of trials, I mean, not a lot of trials, this ESCAPE, this is a landmark trial from the Danish group, Denmark, which has come up, and they recommend that early surgery is sometimes helpful, particularly in halting the process of exocrine and endocrine insufficiency in long term, or it may even improve those patients who are having already having endocrine or exocrine insufficiency. So early surgery will probably has some advantage over the traditional agent that the patient should arm the patient or wait for the burnt out of the disease. So this ESCAPE trial. So in your during examination, either during the theory exam or during the practical exam, if you could mention some of the trials, like in chronic pancreatitis, we talk about the ESCAPE trials. In case of CA stomach, if you talk about the MAGIC trial. So there are so many trials, landmark trials particularly. So I think examiners will be expressed. So please try to take note of the trials while you are reading and try to remember this. So these are the again indications for surgery. The pain is the most common indication. There may be biliary obstruction, duodenal obstruction, or there could be mass. And these are the less common indications. That is portal hypertension, bleeding, complicated pseudocyst, or relapsing chronic pancreatitis. So again, these are regarding timing of surgery. As we said, there is no fixed consensus about the timing of surgery. Now, some groups are advocating early surgery. And I think certain things we should keep in mind, that particularly the patient who have alcoholic chronic pancreatitis, the patient should be warned that the chance of pain relief, or rather recurrence of pain, will be more in those patients who are alcoholic. So unless until they can have abstinence from the alcohol, the surgery is not going to help much, because that will relapse very quickly. So these things are important for the patient counseling. Now, for the selection of procedures, these anatomical factors, that is very important. So you got to have a very morphological delineations of the pancreas. So this can be done either by CT scan, MDCT particularly, or by MRCP. We also got to see the diameter of the pancreatic duct, so that you can plan which type of surgery would be more useful. And if this is associated with other obstructions, particularly the common bile obstruction, or if the patient has got any liver function changes in the liver function test, or the patient has got frank jaundice, so we might have to do additional procedures along with the pancreatic drainage procedures. So this surgical anatomy is very, very important before you undertake any surgery on the pancreas. Look here, the important issue is that this is the arterial supply of the pancreas.
Arcade.
You can see that there is no major vessels around the anterior surface of the pancreas, right? So all this, as we know, the pancreas supplied by the two arcades, anterior arcade and posterior arcade. Those are the branches from the superior pancreatic artery and inferior pancreatic artery, and this other that supplies the head of the head and ancillary process of the pancreas. When the body of the tail of the pancreas is supplied by the posterior pancreatic dorsal pancreatic artery, that comes from behind. So in the anterior surface there is no major artery at least. And similarly, if you think of the veins, you can see the portal veins. The portal vein is behind. So if we stay safely in the middle of the pancreas, so chances of encounter any major vessels, vein or artery, is less, unless and until there is vascularity increases due to the acute conditions of the acute on chronic pancreatitis. So on imaging, of course, initially the ultrasonography gets the diagnosis. Most of the time the patient comes with the ultrasonography plate. And once we see that there is features of chronic pancreatitis on ultrasonography, probably this MDCT with pancreatic protocol, that will be the most useful to image the pancreas, not only the morphology, other than that, any associated pathology, if there is like any head mass or any focal areas, or if there is any vascular anomalies, so that is also very important. So all this can be very nicely interpreted from the MDCT protocol. But if there is still some doubt about in the CT scan regarding chronic pancreatitis, sometimes MRCP may compensate, not always, and MRCP with MRI, and this secretion MRCP, that is one mode of MRCP which is usually used in the very early cases of chronic pancreatitis, where diagnosis is still in doubt regarding chronic pancreatitis. So secretin-induced MRCP will probably give some clues regarding the diagnosis. And in suspicious cases where there is suspicion of malignancy, so we can always use endoscopic ultrasound. We can also take FNSC. So that is supplementary to this others earlier investigations. The role of VRCP is very limited unless and until we plan for stenting of the main pancreatic duct. And nowadays, this spyglass pancreatoscopy, that is another way of doing seeing the pancreatic duct, because these are particularly helpful if chronic pancreatitis is associated with IPN or this sort of pathologies. So other than this routine blood test, LFT is important to exclude any biliary or impending biliary obstruction, and our upper GI endoscopy can be undertaken in the patient with a long history of chronic pancreatitis to exclude any form of portal hypertension. So that should be taken care of before we plan for surgery for chronic pancreatitis. So grossly, we can divide the surgical procedures into drainage operations, resectional operations, and hybrid combination of drainage and resectional, and sometimes of additional may be required. So usually for say a drainage operation, this it's said that the main pancreatic duct should be dilated more than 7 millimeter. However, on an average, 5 millimeter more that can be done for drainage operations. And advantage is the pancreatic parenchyma is preserved, and disadvantage is short-term pain relief, ineffective and diffuse disease, or in head mass. So other resectional procedures are Vegas operation, that is duodenum preserving pancreatic head resection. ISBIC is, as you said, is a V-shaped excision of the ventral husk of the pancreas. This is particularly important, done in case of very small duct disease or sclerosing pancreatitis, very small duct disease. Whipple's procedures are distal and total distal pancreatomy if the chronic pancreatitis is confined to the distal pancreas, or in desperately bad situations, or when there is recurrence, as we were talking about the recurrence of pain patient. Sometimes some of the patient may benefit from total pancreatectomy, and surprisingly, it has been seen that even with the total pancreatectomy, patient does some of the patient does not require insulin for lifelong insulin. So these are Vegas procedures, and I had the opportunity to meet Vegas in one of the conferences, international conference in Mumbai in 2008. And if you're interested, you can just have a look at the steps of the Vegas procedures. I'm just skipping that. And hybrid procedures of phrase operations, that is head coding and lateral pancreaticostomy and Hamburg or burn procedures. So these are almost similar procedures with little bit changes. So head coding, as you can, similarity, that is a head, these are tomatoes, and if you do the coding, so it will be like this. And this is surgical say where the head coding is being done. And phrase procedures, almost lateral pancreaticostomy and phrase are similar, except the coding out of the tissues. So incisions can be midline or localization inside the gastrocolic ligament, exposed the anterior surface, ligate gastroduodenal artery if required. Then define the superior and inferior part of the pancreas. Identify SLB, that is very important. If you can identify the superior mesentery before you put incisions on the pancreas, so you exactly know where is the superior mesenteric vein, and chance of injury will be less. identify the pancreatic duct and open the entire duct. Then either LPG or fresh procedures as per the indications that can be done. Loop is prepared. Complete the pancreaticojejunostomy, jejunostomy, and drain and close the abdomen. So these are the steps we have already discussed, and these are the things we have seen this. These are some pictures of stones of chronic pancreatitis. And this is Izbikis operation. Is again very good examples how this Izbikis procedure is done. So you just Y-shaped tissue from the anterior surface of the pancreas that is been excised, and then anastomosis is done with the jejunum. So this was actually a video I had. And the complications are bleeding, injury to bile duct, pancreatic fistula. The chances are very less, as Professor Shah has told. The pancreatic secretion is almost diminished in chronic pancreatitis, so chances of pancreatic fistula is very less. So, in other words, we sometimes feel happy when we do Whipple's operation that the patient is having associated chronic pancreatitis. So, chance will be post-operative fistula will be less if the patient candidate for Whipple's operation has associated chronic pancreatitis. So, intraabdominal abscesses, that's all rare, and failure of pain relief or recurrence of pain. So these are the few complicated situations in chronic pancreatitis, like duodenal obstruction, like portal hypertension, like visceral aneurysm, that is another complications, that is splenic vein aneurysm. So these are the things which can be associated with chronic pancreatitis, and we need to tackle that accordingly. So these are the splenic artery aneurysm. So this is how the splenic artery aneurysm is after operation. These are the CT scan. This is the vascular embolization. This is a case of pseudoaneurysm of the splenic artery. So this was before vascular embolization, and this is after embolization. So pancreatic ascites is another issue, and that is also need to be tackled. After the ascites is controlled, then patient needs drainage procedures, uniform drainage procedures. So these are the thing again. Malignancy with chronic pancreatitis. This is at least 3 to 5% cases we can find that there is associated malignancy, and we'll have to. There are certain marker or certain signs and symptoms when you should think about the malignancy in case of chronic pancreatitis. So these things are usually jaundice in chronic pancreatitis is less than 5, less than 7 or 5. But if it is more than 10 in case of chronic pancreatitis, that should always arise the suspicion of malignancy. And of course, you'll have to assess for CA99, and of course, CT scan and endoscopic ultrasound might help you to cleanse the diagnosis. And even if that is still doubtful, so we'll have to go for Whipple's operations, and final histopathology will give you the diagnosis. So in summary and conclusion, pain relief and quality of life issues are the main concerns in patients with chronic pancreatitis undergoing treatment. Surgery is indicated for relief of intractable pain and associated complications of chronic pancreatitis. Failure of non-surgical treatment and presence of complication influence the timing and need for surgical intervention. So regarding early surgery, still holds good for even for mild to moderate pain. And careful patient selection, choose appropriate surgical procedures. And this is very, very important. Counsel the patient well before the surgery. Tell them everything about the pain relief, and tell them that all the stones, you may not be able to take out all those stones, because if there is parenchymal calcification, so the stones are going to be there. Otherwise, in the post-operative period, the patient will think that you have done the surgery inadequately. So that's all. Thank you very much.
Yeah. Thank you, Dr. Ghosh, for a very, very nice overview of management options in chronic pancreatitis. So much may not be asked in operative scenario, but you see, chronic pancreatitis may be a long case also. So you should be prepared to have the approach to a patient of chronic pancreatitis. And at the end, again, I want to emphasize that for any operative steps, maybe APR, Whipple's, or whatever, you describe the operative steps in salient paragraphs. Okay. Okay, so it will be
Okay,
easier
sir.
to answer that particular what is being done in that particular steps. Okay, thank you very much. We'll join again on Tuesday. Thank you, Dr. Ghosh.
Yes, the candidate you have done very reasonably well.
Yeah, he has done well. Yeah,
Thank you, sir.
thank you. Good. Thank you.